Greetings, everyone. It's such an honor to be here and speaking with you today. Special thank you to Melissa McQueen and Joseph Hillenberg for the kind invitation. This is going to be a different talk than you may be used to hearing. I'm going to focus on a community of people who, armed with nothing but hope, has possibly, over the past 6 decades, written the best story in medicine. Now, this is my dense disclosure statement. It basically states that I work for the Cystic Fibrosis Foundation and that the foundation makes mission-related investments to advance drug development, and the foundation may receive milestone payments or royalties. Now, just some basics about cystic fibrosis. There are approximately 40,000 people with CF in the United States and maybe some 160,000 worldwide. It's a disease caused by a pathogenic variant in the cystic fibrosis transmembrane conductance regulator gene, CFTR for short, and results in abnormalities in the movement of salt and bicarbonate and water in and out of cells, leading to very dry secretions, which manifests in the lungs by airway obstruction and airway infections, in the gastrointestinal tract by exocrine pancreatic insufficiency and intestinal obstruction, and multiple other clinical manifestations. Despite significant advances, it remains a life-shortening disease. And although the sweat glands, lung, and pancreas take center stage, we know that there are many clinical manifestations that arise from this abnormal movement of salt throughout the body, including liver, sinuses, intestines, reproductive tract, among others. Let's go back in history just a little bit. In the 1950s, parents who refused to accept that their children would not live to school age form what will become the Cystic Fibrosis Foundation. Mind you that it was only since 1938 that this disease had a name beyond what it was known as in the Middle Ages, where there are quotes to the effect, "Woe is the child who tastes salty upon a kiss, for he is cursed and soon must die." These children were thought to be bewitched during the Middle Ages. In the 1950s, we have median survivals of around 2 to 3 years of age. It was Dr. Dorothy Anderson at Columbia University performing autopsies on deceased infants who, in a sense, discover cystic fibrosis. You don't get more deadly or more hopeless than a disease that is discovered by performing autopsies on dead babies. Milton Graub, a pediatrician in Philadelphia, and his wife Evelyn had 2 children with CF. And rather than remain mired in a sense of helplessness and hopelessness, they were determined to fight back. And they began to raise money for a disease that most people had never even heard of. Evelyn sat in her pediatric pulmonologist's office waiting room, and ask yourselves if you would do what she did. But she would stop parents as they came to clinic and would say, "I know your child is probably going to die, and my 2 children are going to die before it makes a difference. But will you join with me and start an organization that can one day make a difference in children's lives?" Now, as opposed to dealing with her grief by running away, she sat there over and over for years, talking to other parents, asking, "Would you join me?" And they did. And they did. They worked out of a basement, and not only did they raise money, but they raised awareness of this killer of children. I don't know if you can see on the slide, but that family's holding a poster that says cystic fibrosis, a major killer of our children. This was the genesis of today's CF Foundation. In the 1960s, the cornerstones for treating CF were being put into place. Modeling itself after polio, a decision was made to establish a network of medical centers. They were funded by local chapters of the CF Foundation, and the first 2 were established in 1961 at Babies Hospital in New York and Boston Children's. By the mid-1960s, there were more than 30 centers. This allowed for some comparison between centers, and in Cleveland, they were claiming to have patients dying at 21 years of age, where everywhere else it was 3. Some claimed that Cleveland was cooking the books. So the foundation gave Dr. Warren Warwick, pictured below, a CF legend who was at Minnesota, $10,000 to collect the data, in effect establishing what would become the patient registry. And as it turns out, Dr. Leroy Matthews, pictured above, at Rainbow Babies, had developed a comprehensive program that started with bonding with and nurturing the parents. He filled them with hope. He gave them hands-on lessons in doing airway clearance. He used antibiotics on a scheduled basis and saw them in clinic every month. He focused on nutrition with digestive enzymes. His comprehensive approach worked and would, in essence, become the beginnings of the CF care model. Today, there are over 130 CF Foundation accredited centers broken down into 286 programs. They undergo annual paper reviews and site visits every 5 years or sooner, depending on the results of previous reviews, all run by the Center Committee, a committee of their peers. They must provide interdisciplinary care and contribute to the patient registry. They're expected to practice continuous improvement and have quality improvement processes in place. The majority of centers also contribute to CF research and educate trainees. The expectation is that the CF care team will have sufficient time from a specialized CF physician, program coordinator, nurse, dietitian, respiratory therapist, and social worker. In addition, you can see the recommended team members on this slide. Their practice should be informed by CF Foundation clinical care guidelines, of which we produce several every year. Again, it is run by a committee and follows strict rules in reviewing the literature and using a standardized format to develop the search questions and finally a vote on the recommendations. Going back to the registry, now it serves many purposes since Dr. Warwick started it to see whether or not Rainbow Babies was cooking the books when they claimed to have median survival of 20. The registry indeed validated that Dr. Matthews and Babies was doing something that every other care center could learn from. And since then, the registry has evolved over time to provide understanding into disease trajectory, establish a framework for clinical trials, undertake post-marketing surveillance studies, continue to monitor differences in outcomes across programs, and facilitate quality improvement. And lastly, promote evidence-based clinical decision-making. So what about this quality improvement I keep talking about? Well, I want to quote Dr. Brent James, a surgeon at the University of Utah, who has said, "Some have estimated that we could achieve as much benefit for patients if we could routinely apply and deliver current best medical knowledge as will be achieved by the next 25 years of government funding for new research." Obviously, the healing profession should vigorously pursue both courses, new biomedical research and care delivery science, as has been done in CF. It represents a massive opportunity for clinical scientists and the patients that we serve. So I want to make sure everyone understands and underline that what Dr. James is saying is that if we only implemented and put into practice what we already know, it would be the equivalent of decades of research. The foundation is taking this very seriously and has supported quality improvement, including training our care teams in how to do quality improvement at their sites. And here I'm showing you the impact of supporting the CF care model of interdisciplinary care, registry data, evidence-based guidelines, and quality improvement. Now, there are always going to be superstar centers, and there are always going to be some centers that lag behind. But importantly, what I'm going to show you in this slide is that the care center network as a whole has continued to improve. Now here you can see that when we graph lung function on the y-axis against body mass index on the x-axis, for adults in the first graph and children in the second graph, Incremental improvements are obvious in 5-year bands starting from 1991 across the care center network. And by this I mean you can see improvement in lung function as the little diamonds go up and improvement in body mass index as the diamonds go to the right. Now, you can also hopefully appreciate that between 2016 and 2021, there is a huge jump, and we will soon get to the reason behind that. Now, the result is not just FEV1 or BMI. The result is that this killer of children is now a disease of adults. Even in 1992, only 30% of individuals with CF were adults. Today, it is 60%. I hope you're starting to get a sense of why this may be the best story in medicine. And yes, it is more than just about lung function or weight. From Dr. Matthews' recognition that he needed to treat the family today, a hallmark of CF care, and that care model is holistic care. As the adult population has grown, they have reminded us that there is more to living with CF than hours on end of therapies. The voice of the person with CF within the foundation has been reawakened. We have quickly evolved over the past 7 years to offer community conferences. Individuals with CF serve and lead committees and quality improvement projects. The chair of our board of trustees is Casey White, a person with CF. Again, the chair of the board of this disease that was discovered through autopsies of infants is an adult with that disease. Best story in medicine? Now, probably no surprise, but as part of providing holistic care, we funded a study to try and understand rates of depression and anxiety. And people with CF and their caregivers were found to suffer from depression and anxiety at 2 to 3 times the rates of the general population. What may be surprising, though, is what the Cystic Fibrosis Foundation did about it. This was a call to action for us. As the chief medical officer at the foundation, Bruce Marshall, has said, there is no health without mental health. So we formed a mental health advisory committee to support implementation of guidelines that were developed. We established a requirement for mental health coordinators at our CF care programs. And the mental health coordinators develop and implement strategies around prevention, screening, treatment as appropriate around mental health. And the result has been we have destigmatized mental health concerns within the CF community and have been able to provide people and their caregivers with the support that they need. Now, I could go on with clinical care, but remember, the initial mission of the CF Foundation was to find a cure for CF. So let's pivot from care to cure. The big scientific breakthrough came in 1989 when the gene responsible for CF was identified. This took collaboration of multiple labs, including Dr. Francis Collins' lab. The adult you see in this photo is Danny Bessette, the child who was on the cover of that science issue describing the discovery of the gene. Now, the initial variant is the most common variant in North America, and it's caused by the deletion of the amino acid phenylalanine at position 508 of the gene. What these researchers probably didn't suspect at the time was that there are over 700 CF-causing variants that have now been identified. In the US, some 90% of the CF population has at least one F508del variant. Over the years, studies have been performed on a variety of therapies called modulators. I'm going to focus on one of the more recent developments and one of the most impactful ones. And that was in 2019 when a randomized controlled trial was published that showed the results of a triple combination of a potentiator with 2 correctors that could treat those who had just one F508 deletion. Remember, to have cystic fibrosis, you must have two abnormal variants of the CFTR gene. With just one F508 del, a person qualifies for this particular treatment. And in the United States, close to 90% of individuals with CF have at least one F508 del variant. The molecules improve both the processing and trafficking of CFTR. Now, what I'm showing you here on these graphs are some of the results of the study. And in blue, you can see a significant decrease in the first graph on sweat chloride values. Now, sweat chloride, again, is a test that is used to diagnose cystic fibrosis, and it's abnormally high in people with CF because of this abnormal movement of salt and water. You can see a decrease of 40 to 45 millimoles per liter, in some cases bringing sweat chlorides into the normal range. And then the impact on lung function, which within 2 weeks, again represented in blue on the second graph I'm showing you, an improvement of 13 to 14% in the FEV1 just within the first 2 weeks of starting this study drug, now therapy, versus the placebo group, which had no improvement and over the 48-week trial had a decrease actually in their FEV1. Since its introduction in the United States in late 2019, this drug has been transformative for those eligible to take it based on their genetics. Now, of course, one can't ignore the survival metric. And one can see that beginning in the period of between 1990 and 1994, so we look at this in 5-year increments, the median predicted survival age was about 29 years of age. The most recent published median predicted survival is now 56 years for a disease that some 60 years ago killed children before they ever got to school age. And what hopefully you can appreciate too is within the last 2 diamonds, a stark increase in the movement up in terms of median predicted survival, which is probably directly attributable to the introduction of these new modulators. Here you can also see the marked decrease in individuals with pulmonary exacerbations. So this is increased chest symptoms, cough, difficulty breathing, reduction in lung function, requiring IV antibiotics. And yes, we had a global pandemic beginning a few months after the introduction of ETI, but the changes were evident prior to the pandemic and have remained despite the lifting of mitigation practices. And you can see this across age groups, whether it's the orange reflecting young children, the green reflecting adolescents, or the blue reflecting adults. The decrease and the maintenance of the decreased rates in those changes. And this graph shows the number of CF lung transplants done per year in the United States, and again, in 5-year increments. And you can see the sharp decline in the number of lung transplants between 2017 and 2022, about 1/5 of the number of lung transplants, and this includes both adults and children. But it isn't all about lung function or lung disease. It is about what matters most to individuals with cystic fibrosis, and that is living a fulfilling life as they define it. And with the introduction of these modulators, we have experienced the baby boom with a doubling or tripling of the number of pregnancies within the CF community. Now, when we look specifically at lung function in children and just look at the FEV1 at 18 years of age over a 20-year span, separating it into normal, which is reflected in purple, and we define as an FEV1 of 90% predicted or greater, versus abnormal reflected in green, which is defined as an FEV1 of less than 90% predicted, you can see that in 2003, only 32% of 18-year-olds had normal lung function. Compare that to 2023, where almost 80% of 18-year-olds have normal lung function. So what might this mean for lung transplantation for children with cystic fibrosis? Well, in 2019, there were 24 transplants done in children with cystic fibrosis. In 2023, there were 3. And then when you compare it to the total number of pediatric lung transplants, and that's in orange on this graph, versus the number done in children with cystic fibrosis represented in blue on this graph, you can see typically throughout history that 50 to 60% of pediatric lung transplants were performed in children with cystic fibrosis. In 2023, only 10% of pediatric lung transplants were performed in children with cystic fibrosis. Our mantra at the foundation is until it's done. And even though what it means to have cystic fibrosis in the United States has been transformed, it isn't done. What challenges remain? Well, first, we need to find therapies for everyone with cystic fibrosis, and ultimately a cure for everyone with cystic fibrosis. And then there's so many questions. Some include, what are the longer-term impacts of the modulators? We don't have long-term data yet. And for those with advanced lung disease, what is the impact of the modulators specifically with people who have established severe lung disease? And when is the appropriate time to list them for transplant? How do we improve the transplant journey and outcomes for people with CF and all lung transplant recipients? For children with CF in particular, in need of lung transplant, should we be concerned about transplant center volumes and loss of expertise? How many pediatric lung transplant programs should there be in the United States? Can the healthcare system think rationally and institute appropriate support mechanisms to facilitate the care of these children in a few centers of excellence, perhaps in partnership with facilitated sharing of care with the local CF programs or the local pediatric pulmonology programs? In 2016, the CF Foundation began to put into place what has become the Advanced Lung Disease Program. We built a consortium of 15 large adult CF transplant programs who agreed to work together to standardize approaches where it mattered. As a result, we've published multiple guidelines, including recommendations as to when to refer, as well as how to manage people with CF after transplant, and also guidelines around palliative care delivery. We have funded multiple rounds of basic science research to improve our understanding of chronic lung allograft dysfunction, or CLAD, a manifestation of chronic rejection, and the number one reason why we don't enjoy the same long-term outcomes for lung transplant recipients as other solid organ transplants do for theirs. We've even built our own database and biorepository where the 15 consortium programs contribute to a longitudinal observational study for CLAD. I hope that what you take away from this talk is how nothing is impossible and nothing is hopeless. None of what I covered today could have been accomplished without committed parents and families who have held thousands of events to raise the money to fund specialized care centers, a registry, and the science that has forever changed medicine. As Margaret Mead said, never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it is the only thing that ever has. Please never lose sight of that simple fact. When we partner, we are stronger together, and nothing is impossible. I thank you for your attention and thank everyone on this slide without whom this work would not be possible. Thank you.